Welcome back. I hope that you are refreshed because we're about to have another exciting and interesting panel. I'd like to introduce Dr. Alan Lewis. As I shared, or as he shared, as everyone has been sharing, the credentials for everyone are located in the program, which is online. So we're not reading everybody's bio, only specific people. So, Dr. Allen, you want to take it away?
Sure, thank you.
Okay.
Welcome back from the break, and isn't this a great day so far?
Yes.
It's really wonderful. Thank you so much for putting this event on, Transport Team. So our next panel has about 45 minutes, and so we're going to get going. And we're in luck because we have a great esteemed panel. You can see we have 5 panelists. They're all experts in their chosen areas. Our panel will focus on academic and community partnerships in advancing health equity research. And before I introduce the panel, let me just say a few words. You know, community partnerships, Downstate's very good at that. Impact 2030, our strategic plan, we're all over that. We don't do, I don't think, quite enough in terms of research partnerships with the community, and that's what our panel is about, so we can do much more of that. But we all know that no academic institution can be viable or sustain itself without being a part of its community. It lives in the community. The community gives us many resources, and we give the community many resources. So it's that symbiotic, reciprocal relationship that we look forward to. So our panel is focused on that relationship as it relates to advancing health equity research. So I have a set of questions, but I think I'm going to start off after I introduce the panelists by asking the panelists to give us their #1 strategy for improving or advancing academic and community partnerships. So you all panelists can sort of ruminate on that a little bit. Let me introduce you, and then we'll get going. And we'll try to save a few minutes at the very end for some questions from folks on Zoom and in this room. So we have, as I said, a very esteemed panel. We have Dr. Aimee Afable, the Associate Dean for Community Engagement and Associate Professor in the Department of Community Health Sciences in the School of Public Health right here downstate. Aimee, if you raise your hand. Thank you, because I'm probably not going to introduce you in the way that you're seated. Dr. Marilyn Fraser, Chief Executive Officer of the Arthur Ashe Institute for Urban Health, Research Associate Professor in the Department of Medicine and in the School of Public Health here at Downstate Health Sciences University. Betty Jung, Coordinator, Center for Health, Community Health Promotion and Wellness, Department of Nursing Services, Downstate Health Sciences University. Brendaly Rodriguez, Senior Engagement Officer, Patient-Centered Outcomes Research Institute, affectionately known as PCORI. And Foti, Program Officer of the New York Health Foundation. So you can see on our panel we have some funders, some community-based funders. We have some folks here at Downstate who participate in research and promote research, facilitate research, as well as some clinical folks. So with no further ado, would you panelists please, one at a time, take a minute or so and tell us what you think your best strategy is that you recommend for improving and advancing partnerships between academic institutions and the community around conducting health equity research.
Muy buenas tardes, good afternoon, for my Spanish speakers in the audience. Yes, from the point of view of the funder PCORI, the Patient-Centered Outcomes Research, what we have found in the last 12 or so years that we have accrued the evidence from all the 2,000 projects on research and comparative effectiveness we have funded, and also the projects to support that and be ready for conducting those research studies. What we have found is that there is a set of kind of foundational expectations that I'll tell you more later, and it's that the first one is building trust, addressing the lack of trust that some communities have and community organizations have with the topic of healthcare research, especially addressing health disparities. That is foremost one of the building blocks in developing sustainable, effective, and meaningful partnerships and collaborations to address healthcare research.
Thank you. Betty?
I find from my experience when working with the community and the academic center, because I have the fortune of working with Aimee in the School of Public Health to help me with students to do community-based research studies, to talk to the community, recruit the community, especially in communities of colors, to engage in research. But also, they also need to be equal partners in this research, not only with the community, it's also community board, elected official, to buy into being a participant in the community studies. We also have to recognize and listen to some of the concerns that communities of colors have, because they have a very long memory of research in the past, which was not, humane per se, nicely put it. And they still have that. We can't just say, oh, well, that's a long time ago. It's changed now. But we have to listen to that. And we can't dismiss that, because they'll remember what happened. But they also have to build trust with us. So research has to be equitable, not only with hospital and academic center, but we have to have the community participant and elected official and community leaders to be equal partnership in this research, so they can buy into being a participant in community-based research. But community-based research is a viable option, because with community-based research, when the results are all put together, data sets, this can be presented through public health, elected official, and really make some policy changes in changing the structural community that is affecting health equity or achieving health equity. A lot of it is social determinants of health. I'm sorry, should I speak louder? A lot of it is social determinants of health, which is a significant factor in achieving health equity, especially in communities of color. So I feel that I know when I work in the community with the students, we do spend a lot of time getting people to buy into the idea of community-based research. And the messaging needs to be simple, it needs to be understandable, and when we are helping a lot of researchers here to recruit participants, it's not just a blast message, but it's also one-to-one personal community engagement. Yes, it's social media as well. When the data sets come out with the evaluation, at least we can address some of the issues of structural health disparities in the community. A lot of it is racism. They have poor experience with healthcare system. So yes, they do want to see change. They want to improve the community.
Thank you.
Hello, yes. In terms of a strategy, I think, just as my colleagues have spoken about, listening. I think that's something that we don't do a lot of, and just coming together at the table to listen to each other. As a community-based organization, you want to talk about what is going on in the community, and you want people to listen to that and respect that, because you are used to the community, you are within the community setting, and as an academic institution also, you have things to offer. And so if we can come to the table and just listen to each other, listen to what is going on within the community, and listen to what can be done in terms of from the academic standpoint, and coming together at a shared space of listening and a place of respect, because as we know, there has been a lot that has happened traditionally in our communities. But if we can take the time to just listen to each other and come together with a shared and develop a shared vision, I think that would be the strategy that I would promote.
Thanks.
Thank you, Dr. Fraser. I want to begin first by thanking all of the partners here, on panelists here, for just the work that they do. Betty is, in the trenches, running our community health fairs, and I see her dedication to this area. And also, I wanted to send a huge congratulations to Dr. Fraser and the Arthur Ashe Institute for Urban Health. They were one of about 6,300 applicants that applied for the open call for community leaders across the nation. And they were in the top tier, one of the top tier awardees. I believe there were about 200 awardees that were selected by this open call, which is a crowdsourcing foundation that Mackenzie Scott, the former ex-wife of Jeff Bezos, contributed to. So I just want to send congratulations to Arthur Ashe for being a top-tier applicant and awardee for that call.
Thank you.
And again, it's long overdue, and I think the award is, pretty impressive, and I look forward to the impact that Arthur Ashe is going to make with this award. But just building on what my colleagues were saying, I think obviously trust is the fundamental value of in terms of what makes community-engaged research successful. But I think what we don't really speak about with regard to trust is the commitment and the time and the longevity it requires to build that trust. And so, and I'm happy to share the panel with, I think, individuals that have done that. You have really dedicated time to building that trust and being there for the community in a sustained way. And so, related to that point, I also want to emphasize that, or the earlier panel talked about funding and sort of funding streams and how as researchers we're often we define ourselves, or we determine what we do based on the funding streams, but those funding streams are time constrained, right? Time limited, and I think as researchers or academics, we have to sort of think out of that box and understand that the research, to really be successful in this type of research, it's an ongoing effort, and if you're not there in the community listening to them, you won't be able to take advantage of the funding opportunities that are out there. So I think in regard to trust, I think we have to consider time and longevity, and that is really what is required to build that trust and being present there for the community. And I wanted to say something else, but I'll end it there.
Thank you. Well, first of all, it's a pleasure to be with you all, and the strategies that I've learned are those that I've learned from Dr. Afable and Dr. Fraser and the rest of the Brooklyn Health Equity Index team. So, as no surprise, my strategy is going to pull off of Dr. Afable and Dr. Fraser's answer. But what I would offer as the perspective of a funder is that a core strategy to support community and academic partnerships and research is to change the paradigm of how we fund research, both in private philanthropy but also in public sector funding. And much like Dr. Afable said, I think that involves substantial and intentional investment of resources to support community partnerships, a commitment of time and multi-year funding to support the depth and breadth of that engagement, a flexibility, not only flexibility in terms of scope of work and budget and the mechanics of funding, but also in terms of the scope of work as it pertains to research, in that co-created research with community requires a flexibility in terms of the fundamental research question, ensuring that that's responsive to community needs, to the ways in which information is generated, to the way that it's shared. And so that requires a freedom from traditional constraints in funding that feels like an imperative to be able to support and enable rather than stifle these types of partnerships.
Okay, great. So we've heard some themes. We've heard trust several times. We've heard talking to and listening to the community, and particularly around developing a shared vision, commitment to build that trust, and changing paradigm for the research funding, and just being more flexible in how we conduct the research and not being tied into static time frames as our funders would have us to be. So the next question for the panel is, given that trust was such a big piece, what approaches have been effective in building trust and collaboration from each of your respective perspectives between academic researchers and community groups? What things have worked to build the trust between those two entities?
Yes, from the perspective of a funder, we have seen and continue to support and have put funding announcement to put the money where their mouth is. With regards to that co-creation, bringing together those voices that of the patients, in our case, patients, caregivers, clinicians, and health systems, all those type of stakeholders, in addition to the community that are being affected. So we're bringing them very early, being engaged as early as possible in the conduit and the design of research, listening. That's part of those foundational expectations I was telling you about earlier. Listening to and adapting for what meaningful compensation it is. Because it's not only about the money or the finances, but also the capacity building and state of readiness for those communities, patients, caregivers, to give the feedback that you're eliciting from the beginning. And of course, throughout the life cycle of the research. And that involves being intentional in those outreach and positionality, bringing them with that flexibility that you were talking about earlier, about how do they want to be contacted, what ways they can provide the solicited input as. We being flexible in the meeting times, and whether it's in person, virtual, providing childcare many times, and just recognizing that life happens, and that is a modifier of what the feedback that you're gonna get. We have learned that through those research-funded studies that we have supported throughout the years. And regarding flexibility, expanding the research funding announcement to allow for a planning year, a period of time in which you are cultivating and deepening some of those initial interactions with the stakeholders, to be a part of that co-creation and modifying the intervention, providing the training, not only for the community, but also for the research team on how to work, how to listen, how to elicit and integrate the feedback from the communities. So those are major strategies that we have seen that have worked in producing impactful research for later dissemination of the results, not only in academic journals being published.
Okay. And by the way, we don't have to go in order, but we can if you want to.
Oh.
It can be more organic. Just jump in.
Well, since I do a lot of the community outreach, and Dr. Marshall, Sarah Marshall is my, like we call our partner. If we have the opportunity to have a group discussion at any of the events, this is where we take the opportunity to talk to a group of people in the community. They may be potential participants in the study, and to explain the studies and to at least have the messaging that is simple enough that they will want to be a participant in the study. So that's one strategy of putting it. In person, as many as we can do at the Health in person to promote the study and have them at least motivate them to be participant in the study. We also know that we have to explain the benefits to them as participants in the study. We also know that transportation may be an issue. There are some studies that promote, okay, you'll get a Metro card or we'll pay for your transportation. That's an incentive for them to be a participant in the study. That's one other aspect of it.
Yeah, I think, thanks for the question. I think it's all about relationships and how do you foster those relationships with folks. Listening to the community, as I mentioned, is really important. Involving the community in all aspects of research, not just coming up with the research questions ourselves as the academician and then deciding like, okay, yes, we'll go into the community, we recruit the community to participate in the study, but having them come up with what what is important, and that happens by listening to them to find out, okay, what do you want to do, and what are some of the issues within the community, and how do we co-create something. And one of the things that we have done at the Institute when we've done our various projects is to go out into the community, do a needs assessment, do focus groups, ask about what things they would like to do, how they would like it to be done, how should the flyers look. I always like to give this example of doing breast cancer work within the salons. And initially we had preventing breast cancer as the name on the flyer. We thought we did a great job in terms of the brochure, preventing breast cancer. And some of our stylists said that their customers just don't like using the word cancer and so on. And they may be turned off by this type of study that's well-intentioned. So we changed that to promoting breast health. And that little change meant a lot. And so those are things that build trust, because you're listening to them and you're implementing the things that the community members are talking about, and also working with them throughout the different aspects of it. How do we disseminate this information? As you mentioned, not just in a journal, but it may be just putting something on a website or putting something out in social media. And those things build trust. And as you involve the community and you recognize the work that they're doing, so funding has to be shared in a certain way, that it's not, okay, you're doing the work and you get pittance for doing the work, and it's not shared equally or shared in a way that's proportional to the work. And so those are all the different things, aspects that once you listen to the community, involve them in different aspects of the work that you're doing, even the evaluation of the work, how it's disseminated, and so forth. Those are all things that work to build trust. And as you have advisory boards, as we have done with community members and academic and faculty, those things help to build trust.
Yes, I agree with all my co-panelists. From an academic perspective, I think it's important to use frameworks that center the community and center the populations we serve, and that has really been one of my guiding forces in the work that I do. I use a framework called transcreation, which is a framework that it's a intervention design implementation science framework. But the first step of that framework is, what are the community assets, right? And so as an academician or as a researcher, traditionally what we do when we think about a research question, or if we think about how to approach the design of an intervention, we turn to the literature. We turn to the peer-reviewed literature. What is the evidence on this? How can we build on this evidence? But what we're learning today is that, unfortunately, a lot of the evidence that's generated is not always applicable to real-world situations. And I know my evaluation students here know what I'm talking about. And so, I try to push the use and application of frameworks that shift our thinking in how we approach the development of solutions to the disparities or to the history of marginalization that we all know of and that we are all trying to reverse, to propel the type of either research, intervention work that we're all doing. But to do that, I think you have to, as a researcher, you have to have a genuine value of what community is and what the expertise that they bring and what their assets are. Because once you do, there's much more promise for the future for sustained efforts and sustainability. So I think that's what I'll end there.
Yeah, thank you. I would also contend that in terms of building trust, in addition to everything that my co-panelists have mentioned, I think that the structure of the research team is fundamental in trust building. First of all, I think in healthcare policy, a lot of attention, rightfully so, is given to the evidence based around race concordant clinical care. As you all know, and as transport facilitates, race concordant research also is instrumental in the symbolic value, but then also the practical value of having researchers of color set a research agenda, engage community, and bring their expertise and lived experience to this work. I also think in the research team, not just the engagement of community partners, but the elevation of community partners as core members of the research team afford the status and the power that community members deserve to set the research agenda. And the prime example is Arthur Ashe being engaged as a core research partner with SUNY Downstate and with One Brooklyn Health in terms of the creation of the Brooklyn Health Equity Index, and with it, their network of community-based partners. And lastly, I would say that in terms of research governance, also is imperative to think about elevating community activists, community advocates, and members alongside the research team to shape how the research unfolds. Lastly, I would just say that this question speaks about building trust with community. As important and as challenging of a task is maintaining that trust, much like my co-panelists mentioned, in terms of not just having this be an extractive endeavor of community members advising at one time on a research question or on a research tool, but rather shaping its implementation, shaping its dissemination, shaping how information gets back into community, so involvement along that process, and also the real stewardship of how research isn't just an academic endeavor for academic sake, but rather that it contributes to real and structural change in the clinical setting, in public health, and otherwise.
So lots of great strategies. Thank you very much, panelists. Things like building capacity, using community feedback, simple messages, elevating the community advocates, listening, co-creation along with research with community members, frameworks that center assets assessments. I want to follow up on this assets assessment component, because a lot of times when we go into communities, we do needs assessments. That's sort of the standard approach to see what's going on before you do research. And I would argue that sometimes we need to take a glass half full approach instead of looking at the glass being half empty and what the needs are, because we know that any urban community of any size has all the ills that exist in the world. So spend less time documenting those ills and more time figuring out what positive resources, i.e. assets, are in place to address those things. And that's a good way to also empower and to stroke the community in a positive way so they realize they have some momentum in doing the right thing. And so what you do is you look at those assets and you figure out what the gaps are in the assets, and you figure out how providers of services can actually provide services more effectively by collaborating more, interagency collaboration, those types of things. So, next question. Given that these are great ideas, how do we begin to change the mindset of a traditional researcher? Because we know that although nowadays in research classes in academia, we're trying to get people to understand how to work more in a more egalitarian way, I should say, with the community. We know that there's still a lot of traditional researchers out there who don't buy into this idea that it's a level playing field and that your community member is just as important as you are as a researcher at the point of research inception and design, all the way to the point of dissemination. So we got a lot of folks that don't buy into that who are producing research. How do we get them to turn the corner? Ideas.
Well, I can share with you what we have done, and it's like changing the funding announcement and incorporating some of those changes, as mentioned before, with the requirements, moving from expectations to requirements. That makes a big difference. Right. Of shared leadership, for example. In several of our latest funding announcements, we have requested that you have co-PIs, one from a community-based organization, and we have a definition that even a state or a local health department can be classified as a community organization in this case, and partnering with the academic research, so they go hand in hand. That's a change, that's an innovation from our at least at PCORI, how we have, and from NIH, Compass in maternal health, and others more coming down the pipeline. So that's a structure, right? And moving from those expectations to requirements on the compensation distribution, and proving to the funder that you are developing a plan for equitable compensation of those partners and stakeholders at the higher level, and of course, as related to the particular study, so at the two levels.
I'm not quite sure how to approach that. It's a good question. I think, I'm assuming, I think if we didn't do more community-based research, by more researchers, and we have good, valid results, it can at least try to impress our public health services, have elected officials involved, community members involved. I think it would be a strength right there to advocate for structural change. But there's a lot of buy-in to changing that. She explained it very well. There's a lot of buy-in to traditional research. Yes, we do see that. But I'll let the others address that.
So maybe to follow up, before we move on, to follow up on that, sort of what I'm hearing from you is the idea of sort of showcasing the successful
That's right.
research that has happened with
That's
a strong
right.
partnership between the
Right.
academy and the community. And the more we do that, the more people will kind of get it and say, oh, we can do it this way, and that can actually work.
Right.
Okay, carry on.
Yeah, so I think different things. One, definitely the way that funding streams are, and in terms of an announcement comes out, how that's worded, and having community engagement really be community collaboration, and that's an integral part of it. I think also training, right? You're having a set of researchers coming up in all the different schools and graduate programs, but training on community engagement being essential in the way that folks are trained to make sure that that's something that's part of their DNA moving forward. I've sat on a lot of community advisory boards and at different institutions, and it's always the people that are about community engagement that are there, right? And you want to know, okay, how do you reach out to the other ones that are not in the room? And I think having sessions and conferences and seminars and those things, that it's kind of like part of your training and part of CME credits, that you give more for those types of events and those types of convenings. I think those are all things that help to bring those folks that may not be woke as yet, those folks that may not be cognizant of the importance of community engagement when you're doing research and bringing those people together.
Yeah, are we going in order again?
I
I don't know if you want to go, because
think we
I
have
feel
to
like that's more
I'm happy to. But if you have
But no, I just want to recognize that there is a shift. I think there is a cultural shift happening at the funders level, for sure. And, you know, my colleague here from PCORI, she has introduced it, but, you know, as an NIH reviewer, I do see it. I see there is a push to have this multi-PI status where the second PI is from the community. So they're definitely, I think that's making an impact. And, you know, again, it's all of us that have been in disparities research, we've seen this for a long time, but all of this is long overdue. But I'm starting to see a shift among funders in terms of how to require that type of partnership. But, you know, as a researcher that has been doing this for a long time, and, you know, without the push from funders or on top, you know, I think still the importance of giving a voice to the community, you know, being able to really represent the community, not just, you know, once you're doing the research, okay, now it's time to involve the community, but really, you know, be a vessel for them. And I will say all the work that I do, you know, the ideas don't come from academia. They come from, you know, the outside, from the community. Where's Alicia? From outside. They come from outside. And so, I wanted to reiterate that I think there is a cultural shift happening, and which is great, which is welcome.
Well, it's heartening to hear that you sense that in terms of funders. I'm going to say I sense that in terms of academic and research institutions as well, though I'll leave it to you all to corroborate that or not. But to the question of how to expand the perspectives of researchers that may be interested in basic science or translational research and embed knowledge and passion for community-engaged research, it starts in the classroom, I would have to imagine, in terms of the theoretical frameworks of transcreation or the training that Dr. Fraser mentioned, equipping with knowledge and skills. But I do think there's a profound impact in terms of experiential learning, and that there is a shift in this way to think about the inherent value of embedding researchers in community and hearing from community members and how that shapes the processes and the outcomes of the research. See this in the research realm, but also in the realms of clinical care and practicing in community-based settings. And I sense that those experiences are as fundamental as the traditional academic and research endeavors that are taking place.
Yeah, and I also want to make a point that, not every topical area is amenable to community-engaged research, like basic scientists, for example. But I think what we need to start communicating to them, because I do have colleagues who are like, oh my God, you're collecting data in this population. Can we tag on this study and collect blood? I think we have to sort of change the perspective or the mindset that it's not just a one-way thing, right? Mm-hmm. So, that's why I've from my perspective, I've intentionally chosen to do practice-based research and intervention research, because I know that these communities have been studied for so long and they never see the benefits of it. And so I think before you can start collecting their blood or you even going into the community, you have to gain their trust and give back. You have to give back. It's not just one way, it's bi-directional. And so that's what I'd like to say to those researchers who are interested in, and I'm not saying they're coming from a bad place, but there has to be a recognition that we have to give something back. Right? And we're not just collecting, it's not just for general knowledge and to advance science. It's really, I'm in public health to, advance equity and health equity. I'm not there to necessarily advance the science of, a particular topical area. So, I do want to make that point. I do see it happen often where I get requests and, I sort of push back on that because of the fact that there's no recognition or appreciation that we have to give back before we take. It's bi-direction.
Brendaly, you had a follow-up?
Yes. And regarding the last points mentioned, I wanted to reiterate that, yes, we feel that cultural change and our contribution from PCORI to that side is not only the funding, but also the learning, the science of engagement. How do we know that something is working? Why is it working here and not there? And elevate the data that is being collected through diverse studies into more of an evidence for developing the theories and inform future research that benefits from this cultural shift. So that's why we're also putting out funding announcements about creating that body of evidence, and it's called the science of engagement, in which not only we wanted to know about measuring what matters and what is meaningful for the different stakeholders, but developing validated measures in this new territory that we are co-creating as we go along. So that is an important aspect for the future on this.
Well, you can see we have a lot of expertise here. Wish we had more time. I'm going to ask one more basic question and then open it up to the panelists, to the audience to ask questions of our esteemed panel. And that is, so, a lot of times you come to these symposia or these workshops, trainings, and you hear a lot of great ideas. But what they lack, in my humble opinion, is that they don't tell you what you can do starting tomorrow as a first step to begin to advance the things, all the great ideas that you've heard, and implement those ideas. So I'm going to ask the panel, think about telling a researcher who's not really currently engaged, an academic researcher who's not really currently engaged in community-based research, but has the commitment and the desire to do that going forward. What can we tell this person? What strategy can we tell this person, this researcher, that they can begin to implement starting, let's just say Monday when they come to work, that will begin to have them to move forward with being a little more community-focused in how they conduct their research. So we're looking for a practical, concrete strategy that a researcher who hasn't done it in the past, but is so moved to do it, starting Monday when they get to work, what are they going to do differently? How are they going to think differently? How are they going to start their process of changing and morphing to be a community-based academic researcher to advance health equity?
Certainly. From PCORI, and for those that have registered to this event, you will be receiving, I put together a handout, a PDF that you will be receiving with the live links to all this. You can, on Monday, or go in and look at how to become more involved by at least learning about this culture's change with this organization, PCORI, and becoming an ambassador, learning, doing those capacity building. We have a big depository of tools that you can download and implement for your study and learn how is it applicable to your population. Coming from studies themselves, that they have released those resources to you all. So you don't have to reinvent the wheel. We also have the Literature Explorer about studies that have implemented these engagement practices. So you can borrow ideas from already successful studies that have decided to share their learnings. You can become a merit reviewer and look at applications from your expertise or you as a patient or a caregiver and help PCORI select the next round of funded studies. And also, lastly, become yourself more involved and knowledgeable, but becoming an advisory panelist. I started with PCORI. I was an ambassador, then advisory panelist, then awardee, because I then learned about the organization, the principles of engagement, and the moving towards the science of engagement, and I was able to apply it. That's what I will share.
Another suggestion is we can ask, are they willing to speak to the community about their findings? Any recommendations they may have to empower the community that can affect change? And truly, yes, we have tools available that she mentioned, but also we have to make sure we have some in-person engagement, because not everybody is computer literate. So we have to recognize that. So that's why community engagement is very important, to share the studies, recommendation. They can be a panelist for some of the community engagement groups. So I think that's something to think about.
Yeah, and I'll just add going out into the community, making sure that you go out into the community and learn from the community and listen, I guess. As I said before, there are some researchers that might have been doing community engaged research, the Dr. Afable, talking to that person and seeing what strategies they might have used. But we can't sit behind our desk and know about the community. You really have to go outside.
Go out.
Yeah.
Yeah, I want to build on Betty's point. I think dissemination is important. So yes, if you want to collect data in a population, you need a plan for how you're going to share that knowledge once you collect that data. And then two, partner with trusted messengers. We heard about trusted messengers during the COVID pandemic to promote vaccination. I think you have to work with and identify who those trusted messengers are and work with them.
I'd build off to Dr. Fraser's point of getting out in community, and what I would say is that I don't know that that's something that you do on Monday at work. I think that's something that you do Monday after work and over the weekend. In being out in community, being in trusted community institutions, supporting and being mobilized by community activists, engaging with your neighbors, I think that has to be done without the intention of a transaction, in that I'm hoping to learn a particular thing today, or unfortunately, I'm hoping to tell someone something today, or I'm hoping to network in this way, but rather just to truly be embedded in community and take in what stems from that with the time that it takes to understand that. And only with that type of depth and longitudinal nature of community connection does this then transform the way that researchers can and funders can transform their thinking. Yeah.
Great ideas, great ideas. The floor is open now. Thank you, panelists, for all your great insights. and
Are there
expertise.
any audience questions?
Lots of questions, a few questions maybe? Up front? Okay, one over here and one down here.
Okay, I have to
I'll
go
direct
to Fred
traffic.
first.
Hi, great job, everybody. So I have a question about, involving the community in research. So we know that there's clinical trials, there's RCTs that are run, and researchers often want to have control, so they don't want the community members to know what's going on in the research that they're doing because it will interfere with what they're trying to do. So how do we get around that? How do you propose we get around some of the control or the constraints that certain types of research imposes?
That's a tough question. As a researcher funded by agency that, where they value those experimental designs, I think that's a challenging question, but I think that funders are also, again, following this cultural shift, funders are starting to welcome and allow other types of quasi-experimental designs that don't necessarily have the level of rigor and control that randomized controlled trials do. So that's one thing, and I'll have the colleagues that are funders here comment on that. But two, I think again it really builds on trust, right? So right now I have two pilot randomized controlled trials with in maternal health and remote blood pressure monitoring. Those build on years of working with the community. So they already know, we had to establish trust before we introduced even the idea of randomizing individuals into we're all worried about the control group, right? And we all feel bad when we do that. But we have to build that trust and have them believe that there's a reason why we're doing it, and that eventually, if we see benefit, that they're going to receive that benefit. So I think it's only possible if you have faith, if the community, you have trust in the community.
Yeah, I think being transparent and letting the community know exactly what the trials are, what the different aspects of those things are. We have done randomized controlled trials, and we have worked with community members, worked with faculty on that, and have an advisory board from the community advise us in terms of what we needed to do and how we needed to go about the different aspects of this study, knowing that this is a study design, these are the things that we're trying to accomplish, but being transparent in that process and saying that these are the challenges. What are some of the challenges you foresee? How can we mitigate those challenges here? How do we recruit? Is this the right place to do that? And have the community really be involved in all aspects of it, but really educating as well and giving the information of what is expected of a randomized controlled trial and all those kinds of things.
Yes. I find that when research is presented to the community, I think the goals and expectations needs to be explained well to them so they can build that trust with the researchers, and that helps. It really does help. And also with the researcher willingness to present their findings after all of the data is analyzed and shared with the community and the community board. And I think that's something that will help buy into the research study.
And I would just add that I think there's certainly limitations in terms of experimental design, but in experimental research and quasi-experimental research and community-engaged research, I think there at times can be a false dichotomy between rigor and flexibility and engagement of community, in that fidelity to and adherence to theoretical frameworks and implementation science, depth and rigor of qualitative methods can occur hand in hand with community engagement, and the flexibility to adhere to those methods, but then also allow for an expansiveness of engagement. And so I've certainly seen from researchers here that is possible.
We'll going to move to our next question. We have two more.
It's not a question. I just wanted to contribute to the clinical trial
sure.
question.
Sure.
So thank you for giving me the chance. From what the keynote speaker said this morning, from the trial of like 4,000 or 5,000 patients for the kidney equation, there were only 197 African Americans in that equation. That is the main problem with the clinical trials. Obviously, it's complex, but we want to be able to encourage minority communities to really participate in these clinical trials. Otherwise, we don't get enough representation in these trials, and because we don't have enough representation in the trials, the trials typically don't really reflect the population that we want to serve. So that's one point I wanted to make, to encourage. So that is then a community academic partnership that we need to develop to improve the participation of minority, patients into clinical trials. The second thing I want to mention is that the traditional way of doing the clinical trials is on the assumption that, when the results come out, you have to trust it. That's the assumption. So if you give the work to someone who is not trained to do the work, right? When the results come out, you can't trust the results, and it becomes very difficult to implement. That is why it's so heavy on the academic side. But over the last few years, though, the NIMHD is actually bringing out smaller grants that make it mandatory for the clinical trialists and those in the university to work with community partners in order to get those grants funded. So that's an opportunity. So if you're a committee member in the audience and then you are interested in doing some kind of research with the academic community, there are now funding streams from the NIH that allows you to get the money directly to the community-based organization, not through the university. Because right now, that's what's happening. The money comes to the university, then the community becomes a subcontractor to the money, and the money then goes to the community partner. But now, there are some grants that don't do that. It's a partnership. So the money, some goes to the academic medical center, and some goes directly to the community. So just be aware of that.
Yeah, great comments. Don't underestimate the value of showcasing how this has happened successfully in the past.
I just want to build on Dr. Salafu's point, and actually Dr. Fraser, being transparent. So, we know we have a problem with underrepresentation of people of color in clinical trials, but we haven't done enough to disseminate why we're doing it, and what are the benefits for them. And I think maybe funding has to be allocated. I'm talking about maybe these clinical trials have to, or the funding for the clinical trials have to take that into account. We don't do enough in advance to communicate our vision, and I think that's also important in being transparent with the research.
Well, I think we're making the same point: transparency and showcasing, show and tell, making sure people understand what has happened. We have a question back here in the back, and go ahead. And we have one on the Zoom as well.
Okay, well, thank you all for your presentation. So my name is L'Oreal Brown, and I have been able to work with recruitment efforts as it relates to addressing health disparities in sleep and Alzheimer's disease. And so community engagement has been like a big component of, building trust and increasing the representation of Black people in our studies. And so for me, cultural humility has been like a big component of, making sure this happens. So my question was, how does that play in your work and what you have done, but also how do we ensure that we hold researchers accountable for the information that they are disseminating, but also to ensure that when they go into the community, they are actually bringing something to the community and not just taking, because what I've seen is that the grants that deal with health disparities aren't necessarily going to the people that represent the population that's recruiting. And so how do we make sure that, for the future, especially past COVID-19, we aren't perpetuating these same racial oppressions and stuff?
Thank you. Ideas from the panel in response?
Well, from the funder's perspective, how we at PCORI we are doing after we provide the funds is the monitoring of the award. And in that, the deliverables are not just the checkbox of consulted with the advisory panel, check completed, and just uploading the minutes of a call. But rather, what we push our awardees is to tell us and assess more of the quality of that engagement activity. What does that mean? And as we progress with the science of engagement, we're pushing them to then look at, okay, what was the input that was elicited? What was the input that was provided? By whom, the audience? And how did that help in the implementation of the research, of the study? Yeah, because then you have to process that information. You have to consult and communicate with the partners about what does that really mean, and the impact it had, whether it was a measure that was selected or cut or substituted for another one, whether it was the part of the implementation, and then we see how that all those decisions combined have an impact in the quality of the work and then future dissemination of study results.
Great. Another question?
Yes. Excellent panel. I just have a question because I'm not a public health researcher, I'm a basic researcher, but I heard you before about science engagement. I wanted you to tell us a little bit more because I think this is something we can all benefit, and also when we work with communities in other aspects. Thank you.
Yes, certainly. And intuitively we have either been participant of positive and effective ways that have worked here, have worked there. And we at PCORI, we wanted to put more scientific thought and looking at the rigor behind it, not only on trying to ascertain in this assessment of the quality of the engagement, what are we doing with whom, by who, and when, the timeliness and of these activities, but because everybody can do, oh yes, an advisory panel. Everybody can do a focus group, or everybody, and still with all the limitations of all those measurements. But it's like, okay, how does that have an impact on what you're doing, on the quality? How is it informing the progress, the process? And that's why we have just put this funding announcement, and actually we have 4 and more cycles coming up in this year and next year. And again, I'll refer to that PDF that you will be receiving later because the live links are there. We want to know exactly how those engagements work. What makes it work on one population versus another? What is the timing of those activities the most benefit to being incorporated into the research cycle and post-dissemination for the results? So there are 2 tracks. The track about measuring what matters, the concept, the domains, the players, if you will, and then the track about, okay, how do we measure that impact? And that track concentrates on identifying, creating, and validating the measurements for that. So please click on those links and get to know more.
There is one online question. So many barriers to reach the community. Fighting for them requires time and money. What are some of your favorite funders that recognize the need to support research with flexible funding to support the CBO and community members?
Favorite funders that support this. Well, of course, we know PCORI.
They're on the panel.
They're on the panel now.
PCORI and New York State Health Foundation. I think, we already heard a lot about PCORI, but I just want to put a shout out to New York State Health Foundation. Foti is a project officer from New York State Health Foundation, and they supported community-based research that both myself, Dr. Fraser, and investigators from One Brooklyn Health participated in. We're developing a health equity metric to hopefully be useful for systems to monitor how they're doing in terms of addressing equity. And that was based, that 10-item measure was based on 2 years of community-engaged research. And so we had a wonderful relationship with New York State Foundation in order to do that. But, Ali has been supportive in having us sustain those efforts and really grow those efforts as well. And as we've been saying, we need advocates in these funding agencies, and Ali is one of them. So I think that is one area that I feel that really contributes to this type of research and the success of this research.
Okay, I think we're well past our time.
Okay.
And so let's give a hand to our esteemed expert panelists one more time. Thank you. Thank you for all your wisdom. And what's next on our agenda, Dr. Straker?
I want to thank everyone, and we're moving toward our scholar presentations. And Lakia Maxwell, who is the program manager for transport, will moderate that session. I also, just while we're doing our transition, I'd like everybody to know it may take a little bit of time to get those documents that are going to be coming to you, only because there's some editing that is done. So don't worry, we will get them out to you, but it may take a little bit more than Monday. Okay. Thank you all very much.
Okay, good morning. At this time, we are going to transition to our scholar presentations. As Dr. Lambert mentioned previously this morning, we have an array of research training programs for our scholars, and that ranges from high school students all the way through to expertise research scientists. I want to highlight our clinical research training program, which is a program that focuses on research, education, and training. And at this time, I would like to introduce Dr. Melissa Lee. She's part of our CREST program. She is the SUNY, she's from SUNY Downstate Health Sciences University, and her clinical, topic is clinical reasoning for abnormal findings, tests, and crafts, best practices for patient safety and physician well-being. Welcome, Dr. Lee.
So I am going to get to stand over here because Dr. Brendaly is much taller than me, and so he's going to stand over there. And so this is actually a presentation on behalf of a number of different people at Kings County, and Dr. Brendaly and I are excited to be able to present today. I'm representing the CREST Scholars Program. I'm the program director for the Primary Care Internal Medicine Residency Program, and I practice primary care over at Kings County.
All right. I thought I was going to be saying good morning, but now I have to say good afternoon. So my name is Dr. Olusegun Bankole and Dr. Melissa Lee. So we're presenting our work on clinical reasoning for abnormal lab and test craft. So this initiative is also part of our collaboration with CREST. Dr. Lee is with CREST and I'm with COE. So our main aim is patient safety and physician well-being. Physician well-being, I will explain it later as we go along. So this performance improvement project was carried out at Kings County Primary Care Clinic across the street. So briefly, I just want to give you an idea of how the volume of patients that we see over there. Kings County Primary Care is part of New York City Health and Hospital, and of course, we take care of underserved population. In 2018, we witnessed about 47,515 visits, and most of these patients, they have Medicaid or Medicare, and over a third of them is either not insured or underinsured. So our staff basically consists of 40 dedicated primary care physicians. We have 52 residents, 36 being internal medicine primary care residents, and 16 IM residents. So apart from giving care, we also treat postgraduate medicine and future healthcare providers. So the objective of the project was to design a clinical tool to teach this to the residents and to evaluate the ability to document and communicate, and also improve timeliness in reporting this to the patients, right? So why this become an issue is because now we have an electronic medical record system, And in-basket lab test results can be a nightmare to most providers, and also creates anxiety for the patient when they see in the app that they have abnormal lab and they have a gap waiting for the provider to get back to them. And of course, we're talking about trust, so this also can lead to lack of trust or confidence in the provider, because the patient might also go to the ER and worried about all these lab results and thinking, they're dying, my kidney is getting worse or something like that. So what we did is that we did a survey of about 36 residents looking at the behavior and the beliefs and the knowledge around in-basket management of abnormal lab results. So we realized about 49% of them only do it after outside non-clinical hours, and about 49% also admitted that they need guidance in how to do this, to manage the in-basket messages for the lab and the imaging. About 86% of them actually believe that it's an important part of their job to do in-basket. So definitely this finding shows that we need to have something in place, a structural system in place to take care of this, and also to train the residents in how to do this. So next slide. All right. So the drivers for this is that, so our aim is the timely communication of abnormal lab test results, but the idea is what we need to change is to develop the algorithm for clinical reasoning, survey the residents, teach them how to use the EMR to facilitate patient and attending communication, and give them a dedicated time. And this is being driven by the fact that the residents, they know how to interpret the results. They've been allocated a non-clinical time for this, and also to develop an efficient method centered around patient communication. So, and what leads to this is because residents have pertinent information that they need to share, and so we need to create a vehicle by which they can, go about this. So, and that leads to of course, to achieve our aim of timely communication of abnormal lab tests. So I'm going to hand over to Dr. Lee.
All right, thanks, Dr. Brendaly. So how do we do this? We really wanted to say, you have an abnormal result. Let's say, has anyone ever had an abnormal result come up in their EMR, right? You get something and it's red, and you're like, what is that? So what if that abnormal maybe is a PSA? Okay, has anyone ever known a family member or a patient to have an abnormal PSA? So it comes up, and what's your first thought? Oh my gosh, right? Like, what's wrong? What do I do with this? And so similarly, as a clinician, first-year resident gets this into their inbox, it might produce similar palpitations or, oh my gosh, what do I do about this? And so we wanted to have a framework to help our residents deal with some of the most common abnormal labs. So this is just what we used. We kind of used an SBAR framework, which some of you may be familiar with. But basically, the first part is like, what's the abnormal test? Is this something that is critical? How do I need to ask for help? Do I need to contact my attending and talk to them about it? If I need to call my patient, do I need to do it today? Do I need to call them in? Can I do this electronically? And if I'm going to call somebody or talk to them, then what do I actually say? Because we realize that all of these different parts of the framework might help build that clinical reasoning. And so we developed them for a number of tests that we'll show you in a few minutes. And we actually posted all of them onto our Downstate website so that our residents could have easy access to this wherever they're looking at their Epic charts. We also Dr. Brendaly mentioned the importance of documentation. So if one resident is making a phone call and one person is calling their attending and calling the patient but not writing anything, then what's the next person going to know in terms of how you're managing your patient care? And so we tried to standardize this, and we're using Epic to be your friend. And so using this, we used result notes. And so the result notes, this is one from one of our senior residents, and it actually gets attached right to that lab. So when the next provider clicks into the lab, they can see, okay, Dr. Srinivasan reached out to this patient, and this is what was communicated. And that also, just with one click, can be sent as a MyChart message to your patient. So this is something where our EMR is definitely working for us. So how did we do this? We looked at charts before and after we taught residents this intervention. And so overall, we looked at 134 patient records, and these are the socio-demographic characteristics of them. Overall, most of them were 45 to 64. This distribution, also of female and male identifying patients, is pretty much on par for what we see in primary care. Most of our patients reported Black or African American as their ethnicity. And you can see about 65% were either self-pay or Medicaid. And again, that's pretty typical for our Kings County population of primary care patients. So what were the most commonly identified abnormal labs? It's funny, if you ask any of the preceptors in this room, and there's a whole shout out to the back row there who came over today, we would have said that you find these all the time, because I had a preceptor tell me, I asked her what her interest was in doing more precepting, and she actually said, I can't do any more because I just can't do that to my own in-basket, because we get copies of all the results too. So this is causing consternation for both residents, patients, and their faculty members. And so by and large, new diagnoses of prediabetes, diabetes, and uncontrolled diabetes were the most common things that we were finding. So what was the documentation like before and after? So the dark blue is before we did this training, and the lighter blue is after. So you can see that we were documenting tests less than 50% of the time to begin with, and that moved to 73% of the time. And we used MyChart a whole lot more after we started this project, and fewer people were waiting until the patient's next appointment to give them their results. So the average time from when the results came out to when the patient had a communication went from 48 days to 4 days. And so on average, this is not something we were proud of, that this was taking us such a long time. Our residents are not in the ambulatory practice all the time. They spend 2 weeks with us and 4 weeks on the wards. That's a really long time to wait for somebody to talk to you about an abnormal result. So we felt like this was the most compelling thing that we found in terms of reason to keep this going. And so here are the results just of the specific survey questions that Dr. Bankole went over. And so the things I wanted to point out is that it seemed like there was much better communication with attending physicians. People already felt comfortable talking to their attendings, but they weren't actually talking to them. And so that's a really nice open channel, and especially having a clinical reasoning tool so that you're already thinking about a process and you're going to Dr. Bankole saying, I have an abnormal PSA, this is what I've done, this is what I think we should do next. What do you think? That's kind of what we want to engender in all of our residents. We also gave residents protected time to do this, because we realized saying do clinic and run here and go to class and also call your patients, like, it doesn't fit in our work days, so how could it fit in our resident work days? So they actually have scheduled time during their ambulatory block to do this kind of administrative work. And the one that we're most proud of is here. So this was something that we hadn't set out to find. I think we were hoping we would find it, and that our residents said that they felt that they were taking better care of their patients outside of regularly scheduled appointments. And so I think the point earlier was made that, like, just don't do something for the sake of doing it, but it's got to be meaningful in order to be sustainable. And so if our residents can feel better about the work that they're doing in creating rapport and building relationships with patients outside of scheduled visits, then this might be something that they too want to continue. So what did we find in general? Overall, better communication with attendings, decreased length of time for communication of abnormal testing, for the time that a result is put into EPIC and when we actually get to talk to our patients, and overall better well-being for our residents and also our faculty members. So just to thank everyone. As a picture of some of our group, so a lot of faculty members, all of the preceptors were involved in this. And so I just want to shout out the context of this within what we do. So I'm very excited to have been able to participate in the CREST program, and it's really given me a lot of background to take the work that we do in quality improvement at Kings County and name it and be able to spread it. And so part of my mission this year was to get our faculty involved and also participate soup to nuts in a project. So this group and others have been, pushing through, putting a poster together, writing up an abstract submission. We're going to SGIM in a couple of months. And so hopefully our passion for being able to do this and the training that Dr. Bankole and I are able to participate in can be spread to the rest of our faculty as well. So thank you.
Thank you, Dr. Lee and Dr. Bankole. At this time, we will take about 1 to 2 questions. We have about 2 minutes for questions. Any questions for them? Comments?
How much dedicated time do you give each resident?
Oh, yes.
Yeah, it's a good question. So we give them a half day, so they have 3 to 4 hours of dedicated ambulatory time to do this work. Yeah. We felt that in order to make this valuable for them, we had to show that we valued the work. And I think that that's something that's been reflected in kind of how we've developed the curriculum. Yeah. Thank you.
Thank you. At this time, I would like to introduce Dr. Crystal Marquez. She is one of our Center of Excellence scholars, and she will be talking about advancing health equity.
Hi, good afternoon, everyone. I'm Crystal Marquez. I'm one of the core faculty members in the Department of Family and Community Medicine here at Downstate. And my project is advancing health equity using a study of social determinants of health documentation, kind of like Melissa's project regarding her residents. This is regarding my residents as well. So we've heard social determinants of health mentioned in every session that we've heard this morning on every panelist. Everyone talked about it. And as we know, social determinants of health are the conditions in which people are born, grown, work, live, and age, and the wider set of forces and systems shaping conditions of daily life. It really is a preventable mortality compared to the 30% of overall health that is really determined by individual lifestyle like smoking or drinking, etc. And these are really sensitive topics. A lot of the stuff that we discussed this morning are sensitive topics, and maybe that's why there's not a lot of buy-in for patients to really discuss these. The prevalence of social determinants of health screen and impact on policy. So there's multiple studies out there, some close to home, like New York Presbyterian had a pilot study that had approximately 13,000 patients were identified with almost 2,000 previously unmet needs, and then they enrolled 944 in services. So there's a lot of unmet needs that are within the whole community, and this is something that's an ongoing research. And so CMS, they have a health equity framework, and they want everyone to have health equity for all the individuals that are in the center of Medicaid and Medicare services. But why is this important now in regards to healthcare? It's because CMS is now making it mandatory for this to be screened when you go to the doctor. So any healthcare system, so Downstate is a healthcare system, we have patients that are Medicare and Medicaid recipients, and when they come to the doctors, we should be screening them for their social determinants of health. This just started this past year, and Downstate is doing it, actually just started doing it in the inpatient services and the emergency care services. And so they're going to start doing it more in a whole universal system here at University Hospital. So what I did, I've done a 6-month pilot project, and so here we talk about in residency training, and I'm a family medicine physician trained, I'm a residency faculty member, and there is no really ACGME guidelines in regards to what we should be teaching our residents regarding social determinants of health, where we should be having them screen for social determinants of health. And a lot of people don't want to do this because it takes a lot of time, and that's what you're going to see as we go along. But it's a very important thing. And so there was a recent study that was published in a family medicine journal that showed out of the 279 people that responded for program directors, 41% of the respondents reported significant formal social determinants of health training in the program. So that's only 41%, very low. And although 93% said it's very important, and 58.9% did not use a standardized screening tool. And a lot of people say, like, barriers are clinical resources, community resources, and inadequate screening instruments. So what I did, I'm a physician here. We have 2 family medicine clinics. One is Suite B here in the hospital, and then we have a satellite clinic known as Lefferts Clinic, or now it's actually Family Medicine Health Medical Center, because we have a brand new clinic that opened up actually this week. And we have approximately 6,000 unique patients between the 2 clinics. And as you can see, these are the demographics of our clinics. And I have 18 residents that have participated in this 6-month pilot project. And all of them have completed the survey that you're going to see the results on. So the 6-month pilot lasted from September till February of 2024. And the goal of the study is for each clinical session, I've asked every resident to have complete a minimum of 1 PCORI screening. A PCORI is, if you don't know, is a validated screening tool. If you Google it, it integrates into a lot of different electronic medical records. It's in a lot of different languages, and it's free. And it's a validated tool. I asked every resident to complete 1 PCORI screening for a patient during a clinic session. Some clinic sessions, they have 8 patients, so it's just 1. And if the screen was positive, I've asked them to either do 2 things. 1, to do a social work referral assistant, social worker assistant referral, as well as add the Z code. So if a person has housing insecurity, there's a medical code that goes with housing insecurity into the medical record so that we can show that documentation over time. My goals are to have the outcome numbers of completed the PCORIs, social worker referrals, and then the ICD-10 codes, as well as post-test knowledge. So over the last 6 months, I've had, this is the amount of surveys done. I've had two residents say that they've completed 30 to 50 surveys. They were obviously really good champions for this project, but I also had 2 residents shamelessly saying, I didn't complete any surveys. And then there was a mix between 1 to 10. The residents' beliefs, and then I also administrated a social determinants of health screening tool to find out their beliefs and their attitudes regarding this project. And a lot of the residents believe that social determinants of health is needed. As you can see, a lot of them strongly agree that this work is very needed, and a lot of them don't believe that this is beyond the scope of clinical practice. But their confidence, even despite having 6 months of doing this, seeing other people do it, myself talking to them over time, not even just during the 6 months, but over their time of residency, they still don't feel confident. And that's the issue, is they still don't feel confident that they can address their patient's social needs. They also don't feel comfortable and confident and having a conversation about social determinants of health with their patients. And they don't even know the resources, despite resources existing. So this is rooms for improvement on a grander scale as the hospital is going to transition into doing this on a very system level. Unfortunately, the results are pending for all those outcomes that I'm looking at. Since I just finished it, and this is all very manual labor, I'm going to collect all these data to show. But I do have about over 100, probably about 120 PCORIs collected total, but the rest will be analyzed. But in regards to the survey, I was able to survey what their reasonings and their ideas behind this are. And a lot of them are time. So having a physician being able to not only screen, find out if it's positive, do the social work assistant referral, and then document, it's a lot. And so figuring out workplace flows to make it better. Also, they found that if they got reminders, so this goes back to the EMR. We here at Downstate, we don't have the beautiful epic that Melissa was showing, but we need to figure out a way systematically to be able to put in our EMR to show that a person needs this screening, because reminders are key. And then having more education and training for residents to ensure that they're doing this appropriately. Additionally, the discomfort, back to trust, having trust with patients. I think the 2 people that completed over 30 of these had a lot of trust and rapport with the patients. I think they're in their 3rd year of residency and probably had a lot more trust. Availability and resources, we can't explain that enough. We need to make sure we have those availability for resources to be able to provide to patients. You don't want to just do the screening. You want to be able to provide the resources once the screening is done if it's positive. Also, program culture and emphasis on social determinants of health. So the residents were the only ones doing this, not my other faculty members, not the hospital, right? So the residents felt like they were stigmatized and they were the ones doing it. And we really need to create a culture where everyone's doing this, where it's important for everyone, not just me, not just you, but everyone in the whole hospital to do it. And then systematic changes for all the workflows and the EMR and so forth. So in conclusion, The residents recognize the importance of addressing social determinants of health. They face significant challenges related to time constraints, workflow system limitations, and patient reluctance to disclose social determinants of health related information. And we need to really address these barriers. It's not just going to take me doing this one research project. It's really going to be everyone in the hospital working together to be able to change this. And despite these challenges, implementing strategies such as electronic medical record notification reminders and continued education and expanding access to resource can ultimately improve residents' ability to address social determinants of health and provided holistic patient care. And that's it. Thank you. These are my acknowledgements.
At this time, we will take questions for Dr. Marquez. Yes.
You can put the next person.
Hello. Hi, Crystal. How are you? This is your excellent project. I have a question what about the reasons? I guess my question is, what about the reasons from the patient side? Were any resistance for them to release information regarding their, social determinants of health?
Yeah, I definitely think there is some resistance to change. So the PROPAR, if you look at what the tool is, it asks you like what your income is. It asks you like how many people live in your house. And there are times, like this was a form that was like given, it was kept in a blue folder, physically handed to patients. And I haven't looked through all of them, but there are times there are blank spaces on the forms. So there are barriers. And I think I've also am doing this as a pilot project where people do outreach. Students, including public health students, are doing this and calling my patients, my personal patients. And I use it the tactic I use for the students, and I've written a script, is saying like, this is for me to help be better acquainted with you and help you to ensure that you have better resources that are needed. But there is a lot of blank spaces.
Thank you. Bravo. You're amazing. I love you. I love working with you. I just wanted to share in terms of the previous comment. I literally, just before I came here, I did a screener. And it is a little off-putting. And so I feel that, my strategy, in addition to sort of using what Dr. Marquez said, that physicians need, your provider needs this information. There are non-medical, factors that are impacting health and well-being. In addition to sort of bringing that down, I actually going through, especially asking about income or asking about history of incarceration, it's really important to take time and to explain, why are we asking that? It's not to shame you, but, having an early experience where you may have been incarcerated or in juvenile detention, that can have a lasting impact on your health and well-being. And these are some of the factors that we want to know about so that we can make sure that we help you. My clinical supervisor for this particular service grant I have, she tried to do the screener previously, and this participant totally blew her off. And so this is a difficult participant. She's out of care. She's lost her phone, and she came in the clinic today. Immediately, I called my team and said, what do we need? Is there something I can do? And we set up an appointment, but I said, I will do the screener because she knows me. And I got her to go through it. And, so it's also about developing rapport, taking time, explaining why we were doing this, that will make it, will help us to reach our clients and to get them to understand that these are things that we want to help you with. At the same time, I got her to sign a consent form for the Unitas platform, and to tell her that, this is a pilot, that, we'll be able to use this platform to be able to send out referrals around social vulnerability. She signed the consent form. And so, when you take that time, we're able to collect this data.
Hi, thank you for your presentation. I work at the Department of Health with community-based organizations that do health screenings like this, and I know Prepare, I always have the worst time saying that word, but I know that they use that screener as well as Unite Us and others. And something that they've run into is similar to what you mentioned having to do with trust in the provider's office, because they're doing screenings in, on the street or in other more casual settings, and so getting folks to take the time to stop and go through the whole thing has been a challenge for them. And I'm wondering how you think or wrestle with the tension between using a validated tool and using screening tools, doing screening in a way that allows for the screening to get done. Because I know some of our CBOs have shortened the tool. They start with a validated tool and then they modify it to meet the needs of, in our case, the level of the funding that they have, because we're not funding them to do full case management work. We just need them to do some screening and some follow-up. But the reality of the screening is that full, let me go through, let me collect all of this information, as helpful as it is and to have for everybody. Sometimes you just need them to stay with you long enough to figure out if they need a referral to a food pantry. So just wondering how you think about that.
Yeah, I agree. We've wrestled with shortening the tool to be able to accommodate and get as much responses as possible. And I think that ultimately is what's going to happen. The hospital is instituting this. The way it's working now, it's going to be 8 questions. 8 of the PCORI questions are going to be used. And to be honest, it's going to be the nurses doing. So I have some hesitancy about that, because the nurses, while they have really great rapport, they already have a long time during their triage process in the hospital, in the office, and they're going to add this to it. And
no more questions.
yeah, but there's some reservations about that, and I've talked to some people that are starting this to do it. But yes, I think tailoring it to our patient population and figuring out the most important things, so whether it's just housing, medications, and food, really is what probably needs to be done.
Thank you, Dr. Marquez.
Thank you, everyone.
At this time, we are going to move to Crystal Pierre. She is from the Arthur Ashe Institute for Urban Health, and she will be discussing Healthy Hearts and Healthy Minds, a framework for conducting community-based participatory research in African American communities in Brooklyn, New York. Thank you, Crystal.
Thank you. Hi, good afternoon, everyone. My name is Christelle Pierre. I am a senior program coordinator at the Arthur Ashe Institute for Urban Health. And today I will be talking to you guys about our Healthy Hearts and Healthy Minds program and how our model can be used as a framework for conducting community-based participatory research in African American communities, or just largely communities of color in Brooklyn, New York. So just to tell you all a little bit about the Arthur Ashe Institute for Urban Health, we are a nonprofit organization that is in-house within SUNY Downstate Medical Center. And a lot of the work that we do is centralized around promoting health equity and social justice. And we do that through our community engagement and research core, which I'm a part of, and also through the Health Sciences Academy. Very briefly, the Health Science Academy is an after-school enrichment program for middle schoolers and high schoolers of color, wherein they're being exposed to STEM and the health sciences in hope that they can diversify the workforce in the future. And in the community engagement and research core, we offer a variety of health education workshop that focuses on chronic health issues and infectious health issues that impact the community that we serve at large. So, understanding our community is key. So one of the things that I want to start off with is our community landscape. As most of you may know, cardiovascular disease remains the leading cause of death in the United States, and that is especially the case not only in New York State, but New York City specifically, wherein we see that African Americans remain 2 times more likely to die prematurely of cardiovascular disease compared to their white counterparts. And when we're looking at Brooklyn neighborhoods specifically, we see that there are high rates of heart disease. And a lot of these communities are where a lot of African Americans tend to reside. And the communities include Bed-Stuy, Crown Heights, East New York, New Lots, as well as Flatbush. But, stepping away from, the death rates associated with cardiovascular disease, it's equally important for us to recognize the impact that cardiovascular disease and its associated risk factors, in addition to comorbidities, have in terms of impacting their quality of life. So how then do we address these disparities and meet the community where they are? And we did that through the co-creation and co-development of the Healthy Hearts and Healthy Minds initiative. So this initiative was a community-based participatory research approach, and we utilized and it was influenced and also informed by the community empowerment model. And the overarching goals of this program was, first and foremost, we wanted to increase the knowledge of cardiovascular disease at the community at large. Secondly, we wanted to build the capacity of our community leaders to become lay health advocates for cardiovascular disease. And lastly, we wanted to empower our community members to not only lead a heart-healthy lifestyle, but also make health-informed decisions for themselves as well as their loved ones. So with that, I want to talk to you guys about our community engagement process. So our process takes on a multi-pronged approach wherein we're not only engaging the community members, but also key stakeholders, such as the barbershops and hair salons in the community. And through this, in fostering and nurturing these partnerships and relationships with these community members and stakeholders, we are establishing transparent lines of communication wherein we're having bidirectional communication, bidirectional exchange of information, in addition to resource sharing. And this allows us to sustainably establish and nurture trust within these partnerships. So with that, I want to dive into barbers and stylists as a lay health advocate. Within our programmatic planning, and I know it's been mentioned earlier, one of the key things is our asset mapping, where we're identifying who our key community partners are. And the reason why we have identified barbers and stylists is beyond just our longstanding partnerships that we've had with them, they are key community leaders. They are trusted community leaders within the Brooklyn community. And beyond just that, they cultivate and establish a space that allows for community members to come in. It's trusted social hubs they establish within their businesses. And with that, in identifying who these key partners are and identifying their capacity to be involved and onboarded into our program, how then do we build their capacity to become lay health advocates? And that's done through our training modules, where we're training them on what is cardiovascular disease, what are the risk factors, and beyond just that, how we're also training them on having crucial conversation with their clientele and with the community members. And of course, lastly, when we're actually implementing these community health education workshops, whether it's in a place of business or virtually, we are reintegrating the barbers and stylists, our lay health advocates, to assist with the support, providing hands-on support, or even helping us in the facilitation of the workshop, reintegrating them into that process. So looking at our community partnerships, overall, between 2022 and 2023, we were able to engage 8 barbershops and hair salons. And through their onboarding and engagement, we were able to identify what were some of the key community needs and what also were their priority areas of interest. And some of the things that we were able to see is that nutrition-related information, fitness-oriented information, as well as information pertaining to stress management were areas of interest for the community members. So with that, we also engaged and partnered with various community-based organizations, and this was by way through participating in community health events, which in engaging the community members, we were able to reaffirm what were the community needs. So again, reaffirming the need for nutrition, physical fitness, in addition to stress management. And keeping that in mind, that later on informed our culturally responsive and tailored curriculum. And one of the key things with this that's very unique is that we took it one step further, wherein we had healthcare professionals and healthcare providers of color who are from the community, who represent the community, co-create the curriculums with us, further ensuring that these curriculums were responsive to the community that we are serving. So with that, looking at our programmatic outcomes largely, through our Healthy Hearts and Healthy Minds health education work, we were able to engage and empower over 280 community members with heart health knowledge. And one of the things that we did in collecting our post-workshop evaluations, when we collected approximately 157 survey responses, we were able to assess for, what were their feelings of empowerment? Was the workshop engaging? Were they able to understand the content of the curriculum? And more importantly, what was the likelihood of them sharing the health information within their social network? And what we were able to see is that 92% of our community members who engaged in this workshop reported feeling empowered to apply what they learned into practice. And similarly, 90% of our workshop participants reported that the workshop was not only engaging and interactive, but that the content of the curriculum was easy for them to understand. And lastly, 80% of them reported that they were likely to share, this validated and trusted heart health information within their social network and with their loved ones. So while there are a lot of lessons to be learned throughout our model of community engagement, I do want to focus on 3. And the first one being the importance of understanding who are your key community stakeholders and your community leaders. Given the central role that the barbers and stylists play within the community and that they're trusted leaders, they were primed to become lay health advocates. And secondly, in terms of, conducting community-based or community engagement research, it's important for us to not simply be cognizant of community voices, but to actually integrate their voices, their feedback, their input throughout the research process. And lastly, in terms of the programs that we do, it's important for us to be very mindful and, to utilize a culturally tailored approach, a community responsive approach, because this ensures that the community long-term is able to be engaged and re-engaged and continue to be empowered to lead a, healthier, lifestyle at the end of the day. So with that, I do want to acknowledge our Health and Beauty Council, which encompasses a lot of our barbers and stylists who, play a major role in the work that we do. I do want to thank our CBO partners as well as other faith-based institutions that, create space where they hold and host community health events that allows us to better understand the community, reach the community, and identify areas of improvement for ourselves in the work that we do. And lastly, our team at the Institute, and as well as our amazing consultants who, are very adamant about creating, work that actually reaches the community. So with that, I do want to encourage you guys to connect with us. Given the work that we do, we also do linkages to care. So if you or anyone in the community are in need of resources or services, don't hesitate to reach out to us. And yeah, that's it.
Thank you, Crystal. For the interest of time, we are going to hold off on questions and we will move to our next presenter. I would like to introduce Janelle Williams. She is our doctoral student from the School of Public Health here at SUNY Downstate.
Good afternoon, everyone. So I am Janelle Williams, and as mentioned, I'm a doctoral candidate in the School of Public Health. Will be defending my dissertation in 1 week, and this forms the basis. And this here forms the basis of my dissertation. So today, I'll be presenting on disparities in human papillomavirus, HPV knowledge and awareness among sexual minorities in the U.S. I'll be looking specifically at HINS 2020, and this is work that I did along with my faculty mentor, Dr. Rose colleagues, as part of a categorical data analysis course. So why HPV? Well, we know that HPV is the most common STI in the US. Its prevalence is really high, about 3.5 million men and 3.4 million women, young adults, have HPV. Now, with HPV, it has been implicated in the cause of a number of cancers. Most of us know about cervical cancer. However, it's also implicated in about 36% of penile cancer, 93% of anal cancer, and 63% of oral cancer. It is preventable, and it's preventable through vaccination as one of the main preventive measures. Most of us are aware that adolescents are the ones that get vaccinated, right? But I'm pretty sure if I was to ask you here, most of you here, how many of you know that someone up to the age of 45 can actually get vaccinated? A number of persons may say no, right? But in 2019, the Advisory Committee on Immunization allowed that persons 27 to 45 to be vaccinated, to receive the vaccine. Even with that said, vaccination uptake is still low. Only 68% of young adults received at least one dose of the vaccine in 2018, and about 16% and 16% women, 3% men received at least one dose. Why? Heterosexuals are mainly the persons that are targeted with the different interventions when it comes to HPV and HPV-related cancers. With that being said, we need to do something about it. Sexual minorities, they're at high risk of contracting HPV. They're also unaware that HPV can be acquired through many forms, right? They're less likely also to be screened because, quite frankly, if you're unaware of it, you don't know to go get screened, and sometimes they're just not comfortable having that conversation with their healthcare provider. And as a result of that, they're now at higher risk and increased risk of developing the HPV-related cancers. So knowledge and awareness, we know, is connected to social determinants of health, especially our socio-demographic factors. We know that that decreases, basically lack of some of our socio-demographic factors can contribute to a decrease in knowledge and awareness. On the other hand, if our people are knowledgeable and aware of it, then that will reduce the rates of cancers. Increasing HPV knowledge and awareness can help us prevent and reduce HPV-related cancers. And I want to stress that increasing that will help us prevent and reduce the HPV-related cancers. Now, when we look at our sexual minority community, there's a lack of research, right? Quite frankly, doing a literature review on this was really hard because there's a lack of research. And HPV literature only looks at HPV vaccine knowledge. You'll find a number of studies, but specifically on HPV vaccine knowledge. And then when we look at the entire LGBTQ community together, you may find a study that looks at lesbians only. You may find a study that looks at gays only. You don't find a study that actually looks at everyone collectively together as a community. And as a result of that, we lack targeted interventions in the LGBTQ community. Now, if we were to implement targeted interventions, we can help reduce and eliminate those HPV-related cancers among that particular community. Thus, the aim of this study was to assess the knowledge and awareness of HPV and HPV vaccination among a nationally representative sample of sexual minorities. How did I go about doing that? Well, I didn't use a cross-sectional design. I used the Health Information National Trend Survey, HINS 5, Cycle 4, 2020, which basically had a response rate of about 36.7%. My null hypothesis was there's no association between sexual orientation and HPV awareness and knowledge among adults 18 years and older in the US. So I built a lot of models. Built a number of models for my outcomes and also my predictors. So I separated my outcomes into awareness outcomes and also knowledge outcomes based on the way the questions were asked in the HINS data set. So I looked at HPV awareness, HPV vaccine awareness, then I looked at the knowledge of HPV-related cervical cancer, anal cancer, penile cancer, oral cancer. The main predictor was sexual orientation, but I also factored in some potential confounders and effect modifiers such as race, education attainment, gender, age, household income, and whether or not they had regular healthcare providers. Summarize all my data using descriptive statistics did some bivariate associations with some chi-square analysis, and I built Poisson regression models to estimate for each of the outcomes. I use R, and most importantly, I applied jackknife survey weights so that the sample, to account for the complex survey design used to collect this, and so that the sample would actually be representative of the non-institutionalized US population, 18 and older. What did I find? Well, if we look at this, you can see that, yes, you're probably saying awareness is high, right? But even though it's high, I still find it concerning that, like a serious concern that 30% were unaware of HPV, and still 27% were unaware of the HPV vaccine. On top of that, let's look at the characteristics of sexual minorities with knowledge on HPV. Now, this is where it gets interesting, right? So if you notice, persons 45 years and older, they were less likely to know about HPV. But the people who were more likely to know about HPV were persons who earned $100,000 and more, college educated, and men, right? That was a really interesting finding. It gets even more interesting. Persons, again, least likely to know about the HPV vaccine were people who have a regular healthcare provider. And that makes me start a question, why? Persons 45 years and older, again, were less likely to know, and those who earned over $100,000, college educated, and again, men, were more likely to know about the HPV vaccine. Now, gets even more interesting here. Let's look at knowledge of HPV-related cancers. 73% persons did not know that HPV caused penile cancer. I'm going to skip oral and I'm going to go to anal. 70% did not know HPV causes anal cancer. And 77%, about 77%, did not know that HPV caused oral cancer. Now, this is really, really concerning because oropharyngeal cancers, the incidence is increasing, not just among sexual minorities, but just our general population on a whole. It's seriously increasing, and it is a public health concern. So, to look at some other characteristics, we see that men were more likely to know that HPV causes cervical cancer. Again, a finding that I find was pretty interesting as well, whereas persons 45 and older and those who had a regular healthcare provider were less likely to know that HPV causes cervical cancer. Then also participants most likely to know that HPV-related cancer, HPV causes penile cancer, again, men. Less likely, persons 45 and older. And then, again, persons 45 and older were less likely to know that HPV can cause anal cancer. So what is this saying? Well, to start off, to the best of my knowledge and my very intensive research literature review, there isn't any study out there that exists like this, right? HPV awareness and HPV vaccine awareness was high for sexual minorities. However, their knowledge on the related cancers were low. Now, I compared this to findings from 2020, and I found that basically this was slightly higher for awareness compared to that finding that found like about 64% adults heard of HPV vaccine, and 60% heard of HPV vaccine, and 64% heard of HPV. Now, surprisingly, as I've mentioned before, men were more knowledgeable on HPV-related cancers, and that may be due to socioeconomic factors, because if you realize the majority of persons who knew about HPV-related cancer had higher income levels and also had higher educational attainment. And if we look at our population, we know that the majority of men have higher education attainment as well as higher income levels within the sample. Now, these results somewhat demonstrate the ineffectiveness of HPV-related cancer education, and it calls for targeted intervention. Some strengths and limitations of this study. So, its novelty, the design to estimate the prevalence of HPV awareness and knowledge, as well as the use of survey weights to control for selection bias. Also, there were some limitations in the fact that it was a cross-sectional design, couldn't establish any form of causality or temporality with that. Residual and unmeasured confounding, even though I control for some confounders, there are some confounders that could not have been controlled for. And the survey is self-reported, so that itself is a bias because you have social desirability bias. They will tell us what we want to hear on that survey. And additionally, the stigma associated with self-identification, so sexual minority may have been undercounted for in this study. My recommendations basically fed into my dissertation, so my recommendation was to repeat this using the entire HINT cycle, 2017 to 2020. So I'm working on that, and yes, in 1 week. So in terms of interventions, propose a few interventions, and there are a lot more that can come out of this study. But first, we need to develop better educational materials that prioritize our sexual minorities and people with low education attainment. And yes, I put men again, because men are generally, I don't want us to forget men, because generally, if we see a particular population is thriving in research, we neglect them and we go to the one that's not thriving, right? Whereas we should still address both communities. And when I say educational materials, I don't mean like handing out pamphlets or so forth. No, we have to do better than that. We need to do like social media campaigns. We know people are always on TikToks. They're always looking at Instagram Reels. So we need to implement these type of education materials. And we also have to meet our sexual minority population where they are, right? Go to their events. Go to bars and just create a safe space on a whole for them so that we can disseminate those educational materials. With all of that in mind, we need funding. Can't do anything if we don't have funding, so we definitely need to allocate more funding towards programs that advocate and promote HPV awareness among the sexual minorities. And lastly, we need a national media campaign, and that could be done through social media. We need to debunk the myth that HPV only affects women. That's not true. Men can be affected by HPV, and only adolescents can receive the vaccine. That's also not true. So these are some of the interventions that I propose. Here are my references, if you scan the QR code. And I just want to say thank you, and if you'd like to get my contact information, here they are. So thank you.
Thank you, Dr. Williams.